All right, so what I was reviewing was just saying that with chemo, we're talking about 4 to 6 cycles. We can add the drug Avastin to lead to some improvement. If you're in the lucky few that has a driver mutation, you can take these pills that work pretty good. But what else do we have to offer? Well, in the last 8 years or so, there's been a move to, after you complete those 4 to 6 chemo, to do something to sort of maintain your response. So thus was born maintenance chemotherapy. Now, we can't, for the reasons I said earlier, continue 2-drug therapy forever because people get worn out. So the plan is to sort of hit them hard with 4 to 6 cycles of chemo to get a really good response, or the maximum response you're trying to get with the chemo, and then give them a break so their quality of life doesn't suffer, and then just go down to a single drug. So that's been a move in the last 8 years or so to try to incorporate maintenance chemotherapy after you finish the first sort of round of 4 to 6 cycles of chemo. You could use a drug that you didn't receive before, or, for example, if you included this drug here, pemetrexed, with another drug, you could get rid of that other drug and just continue the pemetrexed for maintenance. Or you could, especially if you have an adenocarcinoma, when you finish your 4 cycles of chemo, then go on Tarceva for maintenance. Or if you included a 3-drug combination with this drug Avastin plus 2 chemo drugs, you could get rid of the 2 chemo drugs and just continue Avastin. It looks like it's some help, but then the smart people in the audience are going to say, well, what about if you just started the chemo back as soon as you had progression? So what's the advantage of continuing something versus give somebody a break and then closely watch them, and if they have progression, then start it? And that's a question that I don't think has been fully answered, but one that we're continuing to try to figure out. Is there truly some benefit of continuing on maintenance versus adding back chemo at the earliest sign that you're losing ground with the previous treatment? Okay, now, this is the part that Russell wanted me to talk about, because I think this is a very exciting part, not only of lung cancer, but pretty much all cancers. And that is, we've done pretty well, but I don't think we've done well enough with treatment of cancer. So what can we do in the future to make bigger progress? Instead of these singles and doubles, let's get a triple, let's get a home run every once in a while. What can we do to really, truly advance and improve the treatment of solid tumors such as lung cancer? One way is to help your body fight off the cancer better. And this is not a new concept. But what's new is the science behind it, where we're able to figure out some of these targets that play a role in your body's immune system, and also figuring out how the stinking tumor evades the immune system. So it's interesting. Now, there are stories of almost like Lazarus stories of patients who had melanoma or advanced renal cell carcinoma, and then they go see their doctor, and the doctor says, Mr. Smith, you've got maybe 2 months left. I'm sorry, there's nothing else we can do. And then 2 months passes, 3 months passes, and all of a sudden Mr. Smith starts to feel better. And then all of a sudden he's like, I'm going to go back and see that doctor. He goes back and sees the doctor, gets a scan, and there's no cancer there. There's stories like that that are true, and the majority of them in the past had to do with melanoma or renal cell carcinoma, which is kidney cancer. So either melanoma or kidney cancer. And the reason these stories are there is because those are 2 types of cancers in which the immune system plays a very important role. There are case reports of patients who don't know what happened. Maybe they got some illness, or they got food poisoning or viral infection. All of a sudden, their immune system gets activated, and they fight off the cancer. In the same vein, there's a treatment called high-dose interleukin-2, or IL-2. It is a dreadful treatment in the sense that it's very, very toxic. When I was at Wake Forest, when we gave that treatment, people were in the ICU for days because of the risk of low blood pressure, high blood pressure. In fact, it's a very intense treatment. There's a small percentage of individuals who have advanced melanoma who can be cured with IL-2. It's less than 5%, but those percentage of people, they can have disease that's quite rampant and it can be completely cured with IL-2, and it can stay there and persist and it never comes back. And it's similar but not as high in numbers in kidney cancer. So we've known about this for years. We've tried to do something to activate the immune system. We just haven't done a very good job in the past. So for years they've tried vaccine therapy, they've tried all sorts of things like that, and it hasn't worked very well. But in the last 5 years or so, there's been just an upswelling of some real exciting research that's looking at trying to harness the body's immune system to fight off the cancer. Okay, so with that background in mind, it's not surprising that a lot of these new agents, guess where they're being studied? Melanoma. So there's a drug called Yervoy, or ipilimumab, and it's been approved by the FDA. And what it does is that it basically tries to intervene and keep the tumor from shutting down the immune system. Not surprisingly, if you look at the side effects of ipilimumab, it looks like someone who's had an autoimmune disease. Or if you've ever had, is Russell in here? So after transplant, you're on all these medicines to try to prevent rejection, right? And patients can have where they, after transplant, they can, your body can reject the transplanted organ or reject the transplanted bone marrow. So your immune system is revved up super high, and it can cause diarrhea, it can cause a rash, and not surprisingly, a lot of the side effects that we have to worry about with these new treatments are similar to a very heightened immune system, because that's what we're trying to do. We're trying to get the immune system to fight off the cancer, but not heighten it up so much that it starts hurting yourself. And so that's the balancing act with these drugs. There is a durable treatment-free responses in approximately 20% of patients with melanoma treated with this drug, Yervoy. And there's some new drugs, nivolumab and pembrolizumab. Those are good names. And they are second-generation immune activators. They work at a different target, but the same concept. Trying to prevent the tumor from turning down your immune sort of suppression of the tumor. And so right now there are active trials in small cell lung cancer, non-small cell lung cancer, bladder cancer, kidney cancer, not surprisingly, prostate cancer, all with drugs that are similar to these or involving these drugs. So this is where the future, well, this is, I think, one big future advance for cancer treatment, and for lung cancer specifically. So just to summarize, the old approach was basically, let's just keep on trying 2 drug combinations, or if 2 was good, let's try 3. It's just, that's what our thinking was. Or, as I was saying earlier, CML worked. It worked with CML, so let's try the same approach. Let's try the same approach with this drug. But you can't necessarily, it doesn't work in lung cancer because we tried all the combinations of chemo drugs. We tried different combinations. We tried adding 2 or 3 drugs. And unfortunately, right now, we haven't found a driver mutation that is responsible for more than, like I said earlier, 15% of adenocarcinomas. That's the highest driver mutation we found. So what's the new strategy? I think the new strategy is, let's try to hit, instead of one target, let's try to hit something that has multiple arms that it targets. Or try to hit a pathway that is maybe further back so it can affect in a bigger, sort of a global way, the formation of lung cancer. So this is right here. Instead of just hunting for specific genes or drivers, let's try to hit broader pathways. Also, the interesting thing with that is that cancer is constantly changing. There's been several journal articles in the last 4 to 5 years where they have demonstrated that a single cancer over its lifetime acquires and then loses, reacquires, loses mutations. So they did a study where they biopsied patients who had kidney cancer. And they biopsied the primary, and over time, they biopsied any new spot, as many as they could that the patient would let them biopsy. And then they looked at them, they ran DNA sequencing, and they found that the primary mutate, the genetic sequence was different than, for example, the lung met. And the lung met was different than the bone met. And then over time, the bone lesion lost a mutation, but then reacquired it later. So to assume that with one drug that we do one pathway is unreasonable, because the cancer is constantly changing, finding new ways to adapt. And so you have to hit bigger pathways. And I was saying a few minutes ago, let's try to incorporate immune therapy in a way to try to help out the body in fighting off cancer. The last couple slides are about a trial that we have at Virginia Cancer Institute. So I'm one of the physicians at Virginia Cancer Institute. There's 22 of us. We're all over the city. I'm here at Johnson Willis, St. Francis, and I also go down to Petersburg, the south side, one day a week. At our locations, we have multiple trials that are open, some through industry, some through a partnership with VCU. And one of the trials that we have open is this master protocol lung cancer. It's specifically for patients who have squamous cell. And the reason for that, this is squamous cell lung cancer. The reason for that is you've heard this talk. There's a lot of options for adenocarcinoma, not as many options for squamous cell. So they're trying to go after an untapped market of patients who just don't have enough options. And there's a couple things they're trying to do. The big thing why I like this trial is that it's trying to streamline waste. You know, what is the biggest complaint about our government is, for a lot of people, it's that it's too big sometimes, or that it's wasteful, or that, you know, it's not streamlined. It's gotten so big that at times it becomes impersonal, or things don't get done because it's too big. And it's the same thing with clinical trials.